By current trends, I talk about the way we do HTO based on our education and the increased interest over the last few years. There's not going to be an advanced techniques which is not available in India, but I will focus more on our awareness of certain techniques, certain tips where we can achieve the intended accuracy of correction. All over the world, HTO has been having a resurgence of interest with increased number of publications from many different parts of the world. And of course, in India also, the Society of Knee Surgeons have conducted so many webinars focusing on various technical aspects of the high tibial osteotomy. The model high tibial osteotomy is a powerful tool in restoring functional to young arthritic knees. The success of osteotomy depends on patient selection, the accuracy of correction, and always addressing any comorbid pathology that can affect the outcomes. It's very important to know from this paper, in many studies, they found it difficult to achieve an accuracy of correction at the desired level. That indicates that we have still a long way to improve in our execution of high tibial osteotomy. This is a case example in which this 23-year-old female underwent a few surgeries for a multi-ligament injuries which failed, resulting in a varus aligned knee. And she was rightly advised on high tibial osteotomy by a surgeon. But even after the osteotomy, she continued to have pain. Because as you can see here, this osteotomy was done without preoperative planning and using a cable technique as the intraoperative assessment. And if the operated knee is having more varus than the opposite knee. So the HTO as a surgery has a very small tolerance for error. And the patients, for the patients, it will be either a rewarding surgery or a punishment after spending a lot of money and effort. The current trends in HTO is to re-emphasize much more. We are emphasizing on preoperative planning, and much more efforts are being focused to assess the deformity, primarily to know the source of varus, whether it is coming from tibia, femur, or is it a combined deformity, or is there a soft tissue component like a neglected lateral ligamentous injury in this patient, and how do we achieve the accuracy of correction? Whether certain perioperative techniques will help, navigation or robotic technology or patient-specific instrumentation will help. So these are the current areas of research in improving our HTO outcomes. And implant choices, we have a good variety of implant, low profile with the variable adjustment, variable placement of screws are available for us. And we are also using HTO as a productive surgery following a meniscal root repair, following meniscus allograft transfers and repairs, as well as to protect the medial compartment following a cartilage repair. It's very importantly, now we are also focusing our attention on addressing the comorbid conditions, especially the patellofemoral pain and patellofemoral osteoarthritis, to improve our current outcomes in HTO. Coming to the preoperative planning, it's very important to get a full-length standing X-ray view, which shows the hip to ankle in a bipedal stance. Very important to know whether this X-ray is taken properly by looking for the patella, which has to be facing forward. The fibular head should be overlapped by tibia 1/3. And this X-ray should always have a spherical magnification marker, which is fixed to the level of bone in the sagittal plane. So this magnification marker will help us in calculating the amount of which we have to open or close in exact millimeters. And this is a setup which we use to take long leg standing X-ray. This is an institutional setup which is expensive, but there are many Indian versions which give a reasonable, acceptable long leg films as well as it is shown here. So people who have private clinics also should be able to get this facility with a small additional investment. Once again, from these X-rays, we should be able to calculate our weight bearing line and also the mechanical axis deviation. If it is more than 15 millimeter on the medial side and more than 10 millimeter on the lateral side, it is considered as an abnormal mechanical axis deviation. And these knees will need correction, especially in the presence of arthritis and pain. Nowadays, we don't shift the weight bearing line always to the Fujisawa point, but most importantly, most of the cases, we shift it just lateral to the lateral tibial spine. But in very few cases, when the arthritic changes are very well pronounced, involving both the femur and tibia. We shift the mechanical axis to the Fujisawa point in few cases. Coming to the planning methods, we follow the mini-axis method. It can be calculated using a manual tracing of the long leg X-rays. And this is a particular software which I use in my practice called OsteoMaster, which is available in iPad and iPhone. People who can't, who don't have a magnification marker, but still would like to know how much to open on the medial side when doing an opening with osteotomy, and follow the mathematical table described by Hennigu et al. And the next important step is to achieve the accuracy of correction as per your preoperative planning. So certain tips which I follow in my practice is I stick to my preoperative planning. The preoperative planning is done by me in more than 2 or 3 times in more than 2 devices, in computer as well as in iPad. And I don't rely on the cable method or long alignment rods. They are not reliable as a primary way of assessing your correction on the table. When you perform an opening wedge osteotomy, I always use a caliper or a small cut strip of a plastic scale, so that I always confirm that the osteotomy is open to the desired level before and during the surgery. If you're using a thick saw blade, it tends to remove a certain part of bone. So when I'm using a thick saw blade, I tend to overcorrect my opening wedge osteotomy by 1 millimeter. I tried navigation, but I found the margin of error, which is plus or minus 3 degrees, to be unacceptable in the HTO scenario in compared with knee replacement. And this is how we do the perioperative corrections. After completing the biplanar osteotomy, using the tines, the osteotomy, the posterior aspect of osteotomy is open to the desired level, and then the osteotomy is opened by means of this lamina spreader. And as you can see on the next picture, a small cut strip of a plastic scale, which is in this case 11 millimeter, is used to check multiple times that the osteotomy is maintained in the same opening. And here you can see the long rate method, how it can be affected by joint laxity. So the moment you keep the long rate, it shows a less correction, but when you close the lateral joint, you know that your correction is too much. So when, especially in knees where you have excessive lateral joint laxity, the long rod technique or cable method can give you false corrections. And the next important step in your planning and the execution of high tibial osteotomy is to find out the source of varus, whether it is from femur, tibia, or soft tissue. The primary varus has been described as a varus arising primarily because of wear and tear happening in the medial compartment. The metaphyseal varus is due to deformity in the proximal tibial metaphysis, and these are the indication for high tibial osteotomy. These cases respond very well, and they are almost cured by proximal tibial osteotomy. And double varus is a condition where there is medial joint wear as well as lateral ligamentous laxity. Here one should not overcorrect by just going for a bony correction. And then the last cause of varus could be an intra-articular varus, which can be produced by a depressed medial tibial condyle fracture. When assessing your deformity, is very important to know how to calculate these 3 measurements. The first one of them would be the MPTA, or the mechanical medial proximal tibial angle, which is the angle between the mechanical axis of the tibia and the proximal tibial joint surface. The normal value would be 87 degrees plus or minus 3. It is always decreased in varus due to tibial causes. And when you're correcting the varus by doing an opening with osteotomy, it tends to increase, but it should not be overcorrected. Ideally, it should stop by around 94 degrees. The second measurement one should be aware is a lateral distal femoral angle, which is the angle made by the mechanical axis of the femur with the distal femoral joint surface. Once again, normal value would be 87 degrees. It is decreased in valgus, and it will be increased in varus deformities where the femur is the main cause of the source of the varus. And it's very important to understand the joint line congruence angle, which gives an idea about the varus laxity due to the lateral ligament laxity. And the normal value is around 2 degrees. Anything more than 2 degrees should be subtracted by your final angle of correction. So very important to understand the concept of joint obliquity. For example, if you are doing gross corrections, only tibial side, you can see here in this particular cases, we have corrected a little bit, overcorrection was done in the tibia, which resulted in an MPT angle of around 97 degree. You can see the joint surface is now oblique in relation to the perpendicular mechanical axis of the tibia, which can result in joint wear and shear and poor long-term outcomes following HTO. And this is an example of bilateral varus knee. On the right knee, you can see the varus is much more pronounced. And this is a calculation here when you do an MPT and LDFA calculation. MPT is around 100 degree, which is too much, and LDFA is around 90.2 degree. If you happen to correct this entire deformity on the tibia, this is what the result you get as shown in the last picture here. There will be an overcorrection, there will be a pronounced joint obliquity arising. So this kind of gross varus, where the varus is contributed both from the femur and the tibia and the soft tissue, it's very important to correct this gross corrections on one bone alone. So the double level corrections may be indicated in these cases, as would be elaborated by Bhushan later. So this particular patient underwent high tibial osteotomy on the left side, double level osteotomy on the right side. And coming to the femoral varus, it's important that 10 to 15% of all varus deformity can arise in femur. And this is an example of a patient, is a mother of an orthopedic surgeon, whom on the outside we thought we can get away with a high tibial osteotomy because she had a root tear and severe medial joint pain. But the careful assessment of the angles revealed that she had an MPT of around 90 degree and LDFA of around 93.4. In this particular case, the reason for varus is a femoral varus, and if you are trying to correct the tibia, it will result in a joint oblique joint line, which is not desirable, and hence this patient had a root repair along with the lateral closing wedge distal femoral osteotomy. And so this is another patient with an increased LDFA angle here. This is the same patient. This is the software calculation being shown here. Coming to the role of HTO in root tears, the root tear is nearly going to become like an epidemic with much more understanding and techniques to repair them. In India, we face the problem of late presentation when they present with poor tissue quality and repairability. And by the time they come for surgery, there is always significant cartilage wear. And we always have this poor outcomes when we repair this root repair solo. So there is a role for HTO in these patients. Definitely, when the varus is more than 5 degree, HTO combined with root repair is found to be very, very beneficial. And when you're doing a root repair, the significant cartilage injury, it will be beneficial to combine the HTO along with the root repair. So most of these patients will need to counsel before that there may be a need for high tibial osteotomy. As in this case, a bilateral root tear, patient eventually underwent sequential high tibial osteotomy with root repairs with good results here. And the next thing would be to address comorbid factors. When we are doing HTO in many of the patients, we found exacerbation of patellofemoral symptoms after high tibial osteotomy, which took many months to resolve. So nowadays, I make it a point to identify and address the patellofemoral joint issues when I do a high tibial osteotomy, because it's been proven we are doing corrections more than 10 millimeters. The opening high tibial osteotomy causes inferior and increases the patellofemoral joint process. So we are looking at a situation which can worsen your outcome because it tends to aggravate the patellofemoral pain. Especially when you come across lateral facet pain, lateral facet beating, and excessive lateral pressure syndrome. We found lateral retinacular lengthening and partial lateral fascectomy to be very helpful when combined along with high tibial osteotomy. So this is a patient who underwent a sequential high tibial osteotomies. You can see from the skyline view, he underwent partial lateral fascectomy for both the knees and lateral retinacular lengthening as well, along with high tibial osteotomy. Even though this patient had a root tear, medial joint OE, the predominant pain was from the patella. So if I believe that if you don't address this patellofemoral issues in this patient, they will continue to have pain or even worsening of pain following the high tibial osteotomy. And there's another patient who was a 51-year-old female with a very pronounced varus, but on clinical examination, she was jumping with pain when the patellofemoral compression test was done. So when we did scopy, we found severe cartilage erosions of patella as well as trochlea. So in this patient, we did a descending plane biplane osteotomy as shown here along the root repair. And HTO is very helpful, especially when you're doing cartilage repair in a varus situation. So this is an example of a cartilage defect repaired by BMAC cartilage repair. The patient being obese and who also underwent a mastectomy, we thought we'll add a high tibial osteotomy with good result here. And coming to the other role of HTO is along with negative ACL tears, where present with medial joint OA, pain and instability. With the availability of modern variable angle plates, ACL reconstruction can be easily combined with an osteotomy procedure. In this case, because of the variable placement, we are able to drill a tibial tunnel for ACL along with the placement of 4 proximal tibial segment screws for high tibial osteotomy. And another indication is we are becoming much more bolder in offering high tibial osteotomy in elderly patients. So we have been doing HTOs up to the year of 65 in indicated patients. And we are also conducting a small study of the results of high tibial osteotomy in patients aged above 50 years. And it's not the age that matters, it is the status of the knee and the ability of the patient to understand and withstand and cooperate the postoperative rehab. That's very important. So in cases, the 65-year-old needs to do, in selected cases, the high tibial osteotomy can extend the life of the knee for a few more useful years. And an example of a patient, a 15-year-old female who had a left knee root repair 3 years ago, comes for right knee. But by the time we do surgery, the root repair is irreparable. She had NGOA and PFOA. So we performed descending plane tibial osteotomy with the patellofemoral debridement. So to come to the end, the tibial osteotomy is an exacting surgery. When well done, it's a rewarding procedure, but it's a punishment for the patient if it's poorly performed. Pre-operative assessment multiple times using more than one technique is very, very important. And intraoperative monitoring with calipers and cut mark scales have been very helpful in our practice. I wouldn't recommend to use cable method or long rod as a primary way of assessing your corruption, especially when you're not doing pre-operative workup. Future for osteotomy is exciting because we may be performing a lot of slope correction osteotomy for failed ACLs and 3D bone modeling, 3D printed implants, patient-specific instrumentation, and a much more refined navigation robotic technique will make this procedure much more predictable and useful in surgeons' hands in the future. With this, I thank once again for Society of Knee Surgeons of India and Wiroc for this opportunity.